Give me a second. It takes a second to
I think we're
load.
there.
Are you there? Okay, perfect.
Good morning and welcome to the Insurance and Pharmaceuticals Subcommittee of the House Health and Government Operations Subcommittee. This is the place where the bills get discussed and worked on and hopefully get to a point where we can get consensus on a really good product. We have 5 bills on our agenda today. We do have a hard stop at 12:30 today in order to give the HGO committee an opportunity to grab a bite to eat before our 1 o'clock hearings. So if we are not able to finish our bills today, we will carry them over until next Tuesday. Let me tell you the bill order and then we'll begin. We are going to start with House Bill 536. Then we're going to go to House Bill 970, then to House Bill 675, then to House Bill 670, and lastly, House Bill 912. Okay, let's begin with House Bill 536. Lisa, you want to tell us what the bill does and about the amendments?
Sure. House Bill 536 is an emergency bill that requires the insurance commissioner to adopt regulations that may be applied when a national or public health emergency that within the commissioner's discretion affects the state is issued by the President of the United States or by the Secretary of Health and Human Services. A regulation activated in response to a national emergency or public health emergency may not apply beyond the duration of the President or Secretary's declaration. And then there's also uncodified language in the bill that requires a carrier that issues Medicare supplement policies to offer a special enrollment period for certain individuals enrolled in Medicare Part B and Medicaid. And this requirement terminates 1 year after the termination of the national emergency or public health emergency, whichever is later. There are amendments on page 2 in your packet, and the amendments clarify that the national or public health emergency must be based on a serious threat to health resulting from a deadly agent, and it makes a technical change to the termination provision.
Okay, thank you, Lisa. Delegate Commissioner Bahrain, would you like to speak to this bill?
Thank you, Delegate Colson. Just briefly, this was a bill that was put in to assure that the MIA's emergency powers can trigger not just when there is a natural disaster, but when there is also a health emergency. Industry had some concerns about the scope of the kinds of emergencies that this might pull in from the federal health perspective. So I worked with Mr. Celentano, and we were able to develop language that really focused on the exact type of circumstance in which it would be appropriate for the MIA's emergency powers to be triggered. And I think we've reached a good resolution on that, and you have that language in front of you.
Great. So you are good with the amendments, Commissioner, right?
Yes, that is correct.
Thank you very much. I see that Kathleen Hayes has a comment or question. There's a hand up there. Kathleen?
No, I don't have my hand up.
Oh, for some reason there's a hand. Oh, sorry. It's for some reason my cursor turned into a hand on my screen. Sorry for that. Are there any questions from the committee on this bill? Any discussion? Can I have a motion on the amendments?
Move the amendment.
Can I get a second?
Second.
Okay, the amendments have been moved and seconded. Any discussion on the amendments? Okay, those in favor say aye.
Aye. Aye.
Does anyone need to be recorded in opposition? Okay, bill passes unanimously. Thank you. We're going to move to House Bill 970, Managed Care Organizations and Health Insurance Carriers. Prior authorization for HIV post-exposure prophylactics for victims of sexual offenses prohibition. Lisa, what's it do? I mean, I think I just said what it did, but
Pretty much. Yeah, this bill prohibits the carrier or Medicaid managed care organization from applying a prior authorization requirement for a prescription drug used as post-exposure prophylactics for the prevention of HIV. The bill takes effect January 1st, 2023, and applies to all policies, contracts, and health benefit plans issued, delivered, or renewed in the state on or after that date. There are amendments on page 3 of the packet sent around. Amendment number 1 is technical. And amendment number 2 removes the requirement that the prescription drug be prescribed to a victim of an alleged rape or sexual abuse, and instead provides that the provisions of the bill apply if the prescription drug is prescribed in accordance with Centers for Disease Control and Prevention guidelines.
Okay. Thank you, Lisa. Delegate Kelly, would you like to speak to your bill?
Sure. I think you guys, we voted out Delegate Resnick's much larger bill. This is a very small bill that's going to close a sort of incidents that we didn't realize when that larger program was created, sort of folks who presented urgent care outside of hospitals. And I think it's a nice bill and it will help people.
And you're comfortable with the amendments?
I love the amendments. They make
Okay.
it work much better.
Okay. Would you like to move the amendments?
I move the amendments.
Do I have a second on the amendments?
Second.
Okay, that's been moved and seconded. Any discussion on the amendments? Is there anybody who needs to speak to these amendments? Seeing no hands. Those in favor of the amendments, please say aye.
Aye.
Is there anyone who needs to be recorded in opposition? Seeing no one, the bill passes unanimously. Thank you very much, Delegate Kelly. Okay, we are moving to House Bill 675, Health Insurance Changes to Coverage, Benefits, and Drug Formularies Timing. Delegate Hartman, welcome to the subcommittee. Want to talk? Oh, I'm going to Lisa first. I'm sorry. After Lisa describes the bill, Delegate, then we'll give you a chance to talk.
This bill prohibits a carrier from changing the coverage of services or benefits provided under a health insurance policy or contract during the term of the policy or contract. A carrier may change the coverage of services or benefits on renewal of the policy or contract. A carrier that provides coverage for prescription drugs, including through a pharmacy benefit manager, may not remove a drug from its formulary or move a prescription drug or device to a benefit tier that requires a higher deductible copayment or coinsurance during the term of the policy or contract, but they may also do so during at the renewal time of the policy.
Okay, thank you, Lisa. Now, Delegate Hartman, would you like to speak to your bill?
Sure, absolutely. Thank you, Madam Chair. So the bill was inspired by 2 constituent cases where, the coverage was deleted, or a prescription or something was deleted during the year. We have to commit, or the folks have to commit to a year without any change. And I think it's fair that the insurance companies commit to the same year as well. The insurance companies gave some false testimony regarding the prescription coverage, and it does allow additions to formulary. So what they were saying as far as a new drug or something coming on couldn't be added, or if another drug was recalled, they couldn't add something else. The language in the bill clearly does not prohibit them from adding a something as far as prescription benefit. So appreciate being included in your subcommittee discussion. Thank you.
Okay, thank you. Thank you for being here. So I just want to make sure that the committee has some information, and then we have to figure out where the disconnect is. Under the Affordable Care Act, the carriers are required to respond to an appeal on a change in a drug formulary in 72 hours if it's non-urgent and 24 hours if it is urgent. And I understand from the constituents that those time ranges were breached. One of the struggles we have on this committee is understanding that, we only, within the context of the MIA, we only control about 17% of the insurance market. So I'm going to ask Commissioner Bahrain and her team if you would be able to, not at the moment, because you don't have it at your fingertips and I didn't ask you in advance, if you can give me or give us a number of folks who have made these appeals that have taken longer than that 72 hours within the portion of the market that we control. Is that possible, Commissioner?
I am sure that we can provide you with numbers. David, do you have a sense, Mr. Cooney, who is our Associate Commissioner for Life and Health, is on the phone? I think we could probably give you a sense of whether there is currently a high volume or not, but we would have to go look through our records.
Yeah. David? There you go.
Trying with a mute. Yes, we don't get a exceptionally large volume of those complaints currently. I'll have to go back to my team and see if we can pull the specific data. Unfortunately, the way all our complaints are coded, we can only track specific items if we already have a code set up for it. So if we don't already have this code to track this particular type of complaint, we might not be able to pull hard numbers, but I mean, I can check, today and find out on that. And hopefully we do have that as a code. I'm just not sure off the top of my head, but we do not currently get a large volume of these.
Okay, thank you. And I'm going to put one of the carriers on the spot now and ask, what is the impact of not being able to change the formulary when there's a less expensive but equivalent drug that comes onto the market? And any one of you who wants to take that on is fine with me.
I am happy to kick it off. Delegate Collison, Matt Celentano on behalf of the League of Life and Health Insurers. That is sort of precisely the problem here, is that the moving around of drugs on the tiers and the formulary and being able to modify that formulary is one of the only tools we have to control costs. And it's not necessarily the big brand name drugs that are the ones that have the most impact. It is, a lot of the times, it is the drugs that have been around for decades. That could be 40 cents a dose or 50 cents a dose. And all of a sudden, they're $6 a dose. And we are seeing that across the board in the world of prescription drugs. There's, I think I referred to it in the hearing, but there's a Credit Suisse report that notes that price hikes on existing medications that have been around forever accounted for 100% of the revenue growth for 7 of the largest drug makers. It is not exactly the big sticker shock items that are ones that are really messing up the formularies, that these ones that have dramatic price increases that happen during the course of a year. And if we can't move those drugs around up or down to make sure that there are therapeutically equivalent drugs there to meet the needs of the patient, but also to account for cost, we are going to blow up prescription drug spending more so than it already is. And this committee is more sensitive to this issue than most. But as a reminder, maybe a decade or so ago, about 10% of your premium was due to prescription drugs. It's now over a third. And that's a significant thing. Now, the other thing that we wanted to talk about, and we did talk about a bit already, was safety, but being able to remove the drugs. But it's not always the examples like a Vioxx. It might be that we add a prior authorization or move a drug around on the therapy because there might be new types of alerts. Not all of them are recalls. It just might mean that a physician needs to use extra caution with a combination of drugs. And that prior authorization is another safety measure that has to be accounted for, and this bill would prevent.
Okay. So essentially, safety is first, right?
Correct.
And then it's about cost containment.
Correct.
Okay.
Madam Chair, can I give you one other example just to
Yes, of course.
I think it's just a helpful
Mhm.
Example of something that was really positive that we were able to do. A couple years ago, and this is about moving drugs within tiers, right? So it's not just because Matt was describing when a new drug comes on and we want to put it in a preferred tier. We had a Hep C drug that was very expensive on a tier. And a lot of people were on that drug and they were spending a lot of money for that drug. And then I think it was called Mavorite. I may be pronouncing it wrong. I can't remember. And this is just based on a couple of years ago remembering, came onto the market. And it was a blockbuster drug. It was less expensive, and it also was used at a less amount of time, I think, for people. And it was a really exciting breakthrough. It came in at a lower cost. So based on, we have two options. We could try to put it on a lower tier and have everybody use that drug because that's the preferred cost and move the other drug higher. But we were able to leverage the ability to say, this great new drug came on and we're going to put it on a certain tier. You, whatever drug it was, or so much higher, if you're willing to negotiate a lower price with us, we'll keep you on the lower tier. And we were able to do that. So we actually reduced healthcare costs for our members by being able to negotiate mid-year to get costs down to keep a drug on a tier. So there are some really positive things that happen as well when we can try to negotiate with pharmaceutical companies to keep costs down for our members. So that's just another example.
Okay, thanks. Okay, I know Delegate Saab has been extremely patient. Delegate?
Thank you, Madam Chairman. So I guess a couple of questions that I have, and I think either Matt or Deb can answer that. So when usually you have contract with PBMs or with formularies, are the prices locked in for a year, or do they just change throughout the contract?
They can change throughout the contract year. And in fact, I just saw an article just the other day that showed, let me see if I can even find it again, that in mid-year in July last year, pharmaceutical companies increased prices on 32 drugs, I think it was, mid-year.
Even if you're under contract, they can still change prices on you.
Mm-hmm.
And when those changes are made, do you alert the members, let them know that this particular medicine is no longer available, this is the replacement for it, or do they just find out when they get prescribed and they find out?
I think I'd have to go back and look at the law, but I believe we have to notify them.
30 days. 30 days prior to removing the drug if there's a rapid fluctuation.
So when they change and you can't find a replacement, you obviously keep it on the formulary because there's no substitute.
Correct.
And then you basically eat the cost if you can't find any other alternatives.
Or yes, unfortunately, healthcare costs go up and we all know what happens at that point.
But it won't go up until the following year because
that's right.
Members don't get the new premium. Okay, thank you, Chairman. I appreciate it. Thank you.
Thank you, Delegate. Dana?
Thank you, Chair Collison. The one point that I wanted to make here is that not to lose sight of the effect on patients when there is a formulary change mid-year. And the patients who are most affected by this are those who with chronic conditions. And, you did hear testimony during the hearing, but again, I want to acknowledge the fact that Maryland does have an exemption process for being able to request to stay on a drug. But I think that there is two issues here. There is the issue for the exemption process for the person who has never been on a drug. But I don't know, and I don't believe that that exemption process really is working for those who are on a drug right now. For example, we do have a step therapy process that we put into place back, I think, in 2014. And there it basically says that a carrier can impose a step therapy on an individual who's been on the drug for 180 days. And I am not proposing 180 days because we're only talking about one contract year. But if in the clinical judgment of the prescriber, that person is doing well on a drug. I think if somebody has been on a drug and is doing well, then our exemption process should be clearer in order to allow that person to stay on a drug, at least through the contract year, because as it's been stated, that individual doesn't have the ability to change plans. So if they pick that plan specifically because they have a chronic condition to stay on a drug, to 3 months after the plan starts, they are being told now that they can't stay on that drug. It's extremely unfair, especially if they have been stable. And I think if we're not going to prohibit mid-year formularies, then we need to take a closer look at those individuals who are on a drug and are stable, being able to ensure that they can stay on that drug through the end of the year, the plan year.
Thank you, Dana. Delegate Hartman.
Thank you, Madam Chair. And Dana said it much better than I could have said. So that was addressed one of my concerns. The other was the, the great story from Care First that we heard, from a few years ago, where a new drug came and it was able to be added to formulary. That same story can happen if this bill were passed. This bill doesn't prohibit a new drug from being added to the formulary, and you could still negotiate and keep your other drug at a lower tier or whatever. It doesn't allow you to raise a tier. It allows you to add drugs to formulary, but that great story could have still happened even if this passed.
Great, thank you. Kim Robinson.
Good morning, Delegate Collison and members of the subcommittee. Kimberly Robinson with Cigna. Just a couple of things to add to the conversation. I appreciated Delegate Bhandari's question. I just wanted to make sure everybody was clear when we talk about who's raising the price in this conversation. It's the manufacturers, right? It's the pharmaceutical companies. It's not the relationship between the PBM and the health plan. It's not our PBMs who are raising the price on us. It is the manufacturers who are raising the cost of their drugs. At the end of the day, even when that happens, all of the PBMs, because Maryland law requires, but they had them anyway, have what's known as a Pharmaceuticals and Therapeutics Committee. They are independent of the PBM. They're not employees of the PBM. They are providers and specialists and experts in all types of diseases who review the formularies regularly, because the law requires that they're doing this on a periodic basis, so that they're assessing all of the metrics around our drugs, right? And the leading one is safety. The leading one is efficacy. They're looking at all of the drugs on the market, and then they are the ones who are designing the formularies to balance both access to safe and effective drugs, while also keeping in mind the cost, because at the end of the day, patients are often paying these costs. And although many of us are accustomed to formularies that are based on co-payments, everyone's formulary is not a co-payment based formulary. So if you're a person whose formulary is based on co-insurance and you're charged to pay a percentage of your drug costs, when those drug prices go up, that patient's cost is going up immediately and directly in proportion to that increased drug cost. So often, again, when safety is not at issue and there's a therapeutically equivalent drug that's being substituted in that lower tier to make sure that there's still access to the medication, that's when the cost conversation comes into play. Because if I've got a co-insurance based plan, or I'm in a high deductible plan where I'm responsible for paying the cost of the drug before my copay kicks in, the patient, even though they're in that lower tier where they may have a lower cost sharing percentage or a lower copay, once they reach it, they too are experiencing that same increase. They're feeling the same pain that the plan is when that drug price goes up. And so that is why both Maryland's law and the ACA contemplates having that exemption process. This is not a change that's really about the individual for whom going from generic to generic is at issue, even going from brand to generic is at issue. That exemption process is focused on that person that I think Ms. Kaufman was talking about, right? That person who is already on a drug, performing well on a drug, and there's a good argument for why it doesn't make sense to move them off of a drug. It's not just because we, as humans are sort of uncomfortable with change. If you're not contraindicated, it's one thing. If there's not a reason why your doctor thinks that they know something about the new drug that's a problem is another thing. But when there's a reason why somebody ought to stay on it, we absolutely have an exemption process to make sure someone on an existing drug has the opportunity to stay on it. And I think that's really important to remember. I know that sometimes providers forget because, of course, if they're dealing with patients under different policies, every policy is not a Maryland policy. But I think it's just really important to remember that exemption process is there for exactly the scenario that I think is being argued as why this bill is needed. When this bill comes into effect, right, the challenge becomes formularies are done across all members in a plan. Plans do not all renew on the same day. If every plan in the state renewed on January 1st, it would be something easy to implement. But the reality is employers bought their plans to renew in December and January and February and March, June, July. And so the formulary is static for that year, but the plans are not all renewing at the same time. So the administration of trying to create now many individual formularies is expensive. It's a lot. It's very administratively burdensome and challenging, for employers and plans to be able to manage. And then lastly, I think Care First gave a really great example. I think what's not sometimes understood about how this becomes a chilling effect on what they accomplish there is that while the bill would still allow it, it takes the incentive away from the person or the company they're negotiating with, right? But I'm negotiating with the plan with the company with the higher drug, and they know I can't take their drug off the formulary anyway. What is their incentive to give me the lower price to stay on it? The stick in that case was the threat of your more expensive drug will come off of my formulary in favor of your competitor. What made that effective was the ability to, in fact, move that drug if necessary. And so when they know Maryland says you can't move my drug anyway, Deb, they don't have the incentive to give Deb the price break that they did. And I think that's also, just part of the real negotiation landscape. I think it's important the committee understand that effect as well. And I'll be
Thanks
quiet.
for allowing me to remove my hand, Kim. Thank you.
Yeah, I noticed that. So with that, I would like to move that we hold this bill until next week and see if we can get some information from MIA on the, utilization of the exemption process and if there's been a lot of appeals on it. And then we'll bring it back with the information that we have now. Any objection from the committee on this? Okay, then thank you very much.
Apologize to Delegate Saab. I said Delegate Saab and Delegate Bhandari when I meant Delegate Saab. So I just wanted to apologize to Delegate Saab.
And I'm sure he accepts that. Right, Delegate Saab?
Thanks, everyone.
Thank you, Delegate. All right, we are going to move to HB 670, Maryland Healthcare Commission Study on Expansion of Interstate Telehealth. This is Delegate Wilkins. Lisa, what's the bill do?
This bill requires the Maryland Healthcare Commission, in consultation with specified agencies and stakeholders, to study ways that interstate telehealth can be expanded to allow state residents to use telehealth to receive health services from out-of-state practitioners.
Okay, thank you. Is Delegate Wilkins is here. Delegate Wilkins, would you like to speak to your bill?
Thank you so much, Madam Chair, and thank you to the subcommittee members. Yes, this bill, you may recall the hearing, is really about us just making sure that our residents are able to access interstate telehealth. The reason that it's a study bill is that, as you all know, this is a very complex issue with layers of insurance and licensing and compacts. And so what this bill intends to do is to bring the experts around the table to figure out the best way for us to move forward with expanding interstate telehealth services.
Okay, thank you. So, and I will just say off the top of my head, in terms of the testimony that we saw, both written and oral, there's a lot of confusion about the intersection. Oops, Ben, around the intersection of the compacts, of licensing, of medical malpractice insurance for physicians. All of those things are tied up in this bill. Who is there? Someone who would like to speak to this? Ben, Stefan from MHCC, are you?
So I'm going to thank you, Chair Cullison. I'm going to ask David Sharp to speak to some of the details on this bill. I just want the committee to remind the committee that we are heavily engaged in a telehealth study currently, and that represents some of our concerns. Simply not that it's not important, but rather just how many resources we have. David, why don't you take over from here?
Sure, good enough. Thank you, and good morning, everyone. As noted, the bill looks to address some of the challenges with the insurance companies, including the malpractice issues. That is a fairly large issue, which we've heard a good deal about over the years, regarding whether or not a provider has coverage has been questionable in some instances in the past, and oftentimes the providers don't know exactly what coverage they have. What we do know is that the use of interstate telehealth or health compacts is advancing. So we think there's been a good deal of energy behind trying to put them in place. They are mutually agreeable for states, so they bring to light the health oversight of providers who are engaged in these compacts. They also require a higher level of standard than just basic licensure in the state. So there's a good bit of governance, and it allows the health occupation boards in those states to appropriately manage individuals who are participating in the compact and providing care. We are doing a study, as our executive director noted, and it's been mentioned before, on the use of telehealth for audio only and audiovisual technologies. While we don't expect this to be a core item that's discussed within that report, we expect that there'll be some mentioning about it. We think that this is a critical issue for the expansion of interstate telehealth, but we also aren't sure whether or not we would suggest to the committee that it may be best to wait for the telehealth compacts to advance and fill the gap. So we have broader issues around liability coverage for providers, and we also ensure that individual patients have protections in place around healthcare that they receive. Happy to answer any questions.
Thank you, David. Is there anyone else? Scott, you want to speak to this?
Yeah, I just want to kind of echo the comments that were made about the compacts. The nurses had put in some amendments that, I just wanted to flag about prioritizing looking at the compacts that are coming down the road, the compacts that we already have, and kind of seeing if there's ways we could adopt some of the ones that we haven't adopted so far, and then also work with some of our neighboring jurisdictions to make sure they also adopt them as well, to make sure we have as much reciprocity, at least locally, as possible. So I won't belabor the point about why we like compacts, but I think that was one thing we wanted to kind of flag.
Thank you, Scott. Steve Wise?
Thank you, Delegate Collison, speaking on behalf of MedCai. And first, let me thank Delegate Wilkins, who reached out in advance on this bill just to kind of get our thoughts on it. And we think that the Interstate Medical Compact, for example, is already doing some things in this regard. 700 doctors, I believe it is, from out of state have come licensed through that. So that enables them to see patients in Maryland. The flip side of that is, what about the Maryland patient that leaves but has been seeing a Maryland physician? And we think the answer to that lies in some other things that the Board of Physicians is either doing or already working on. One, of course, is the compact, but they are also trying to enter into reciprocity agreements with DC and Virginia, which would be even more streamlined than the compact. And there's also licensure by endorsement that they're working on. So I think in the Board of Physicians case, they're doing some things that advance this. May not be moving as quickly as everybody would hope, but I think everybody on this call would agree that telehealth wasn't a gradual ramp up. It was a light switch that went on in 2020, and the infrastructure around that is still kind of coming together. But we think it is moving in the right direction with what is already being done. Thank you.
All right. Thank you, Steve. Erin, Dorian?
Thank you, Madam Chair. Erin Dorian from the Maryland Hospital Association. I think what you've just heard, both my colleagues, Steve and and the Board of Nurses talk about, actually points to the need for this study. MHA has always supported these compacts. We have supported the compacts for every health occupation that is out there. We are a big supporter of IMLC, the Interstate Medical Licensure Compact, but we don't think that oftentimes these compacts will be enough. We've heard outlines a lot of the issues that go into interstate telehealth. And we just think that in order for the General Assembly to make good decisions next year about both the PTAA and where we are going with mutual recognition of healthcare providers across state lines, that it is necessary to do a study like this. I completely appreciate what Mr. Sharp and Mr. Steffen said about their resources, but we do think that we trust and believe in MHCC and are really hopeful that they will be willing to take this on either as its own study or as part of the study they're already doing under the Preserved Telehealth Access Act.
Thank you, Erin. Debbie Rifkin.
Hello. I'm agnostic as to whether we do a study now or we do a study later through the Healthcare Commission. I think it's important for us to look at these things. So I don't have any issue of who or when we look at how to expand telehealth. I do just want to raise one issue that no matter when we study it and in what format, there's one thing that I don't think we really talk about a lot. Am I frozen? Oh my goodness. One thing that we don't talk about a lot, and I don't know the answer to it, and that's why I want it to be raised and we need to think about it, is I can't figure out when providers are out of state, how they fall within a network with a carrier. And so any member who says, oh, that provider has been approved either through a compact or through some other arrangement, they've been licensed, but they're not in the carrier's network, there's going to be a cost to that member. So there's two pieces of this, and this is the insurance subcommittee. So I just want to make sure that we highlight that. There's one thing about expanding the amount of practitioners who can see Maryland residents. There's another component of it that we have to make sure that that doesn't mean that someone who's in an HMO or in Medicaid can go out of network and see that member without having a cost impact, or even in a PPO. They will also have a cost impact. So I just want to raise that so we talk about it whenever the timing is right. And then we think about that in part of the discussion.
Okay, thank you, Deb. Delegate Saab.
Actually, Deb exactly hit the nail on the head. That's exactly what I was going to suggest, that this is an important piece of this whole thing, because if you're going to do it, you want to make sure that those providers are in network, because we run into the same issue that we've had many bills this year, that people are out of network, they're not covered, and it creates some unintended consequences. So Deb pretty much raised my concerns there. So thank you, Deb.
Okay. Thank you. Let's go with Delegate Krebs.
Just following along that line of conversation, just to think about it. So what has happened during COVID, during the very same situations? We've been in this, who's paid for it and how does that work? I guess I ask it to Deb or whoever wants to answer.
Yeah. Deb, do you have information on that?
I don't know. I don't know what I have to find out. I really don't know if we had members going outside of the state or not. Certain, I'm gonna have to ask that question.
Thank you. I mean, we have a little bit of history. It'd be nice to know, learn from a little bit from that. Thank you.
Okay. I think there's some things we don't know yet. That's one of them. I think we need to be really clear about what is included in the study. We need to, because we do need to understand the intersection between the compacts and the medical malpractice. So I'd like to suggest again that we hold this bill, we gather some information over the next week, taking the information that we got now and see, how we can define the study, and if MHCC is given their workload and capacity, is that the right entity, or are we looking at something bigger? So let's take the week to think about that. Any opposition to that? Okay, thank you all. Thanks for being so cooperative. Last bill for the day is HB 912, and that's health insurance provider panels coverage for non-participation. And Lisa, tell us what it does.
This bill requires carriers and that includes health maintenance organizations and dental plan organizations. Everyone except, I guess, managed care organizations, to cover mental health or substance use disorder services provided by a non-participating provider at no greater cost to the member than if the services were provided by a participating provider under specified circumstances. Carriers must also inform members and beneficiaries in plain language of the right to request a referral to a specialist or non-physician specialist, and the Consumer Education and Advocacy Program must provide public education to inform consumers of that right. By January 1st, 2023, the Maryland Healthcare Commission must establish a reimbursement rate for non-participating providers that deliver specified services. The bill would apply to all policies issued, delivered, or renewed in the state on or after January 1st, 2023.
Okay, thank you, Lisa. Madam Speaker Pro Tem, would you like to discuss your bill?
Sure. So as you know, through the testimony that I provided, that the concern still is at hand of the carriers not having adequate behavioral health providers in network. And so to that end, listening to the providers that have attempted to get in the network, of the challenges of having it done in a timely manner, but then also the rates that were offered certainly has been a grave concern. And then listening to directly the citizens that have had to go out of network and have found it time and time again very difficult to pay for those overages. So that summarizes it. My goal with this particular bill is to ensure that there's a plan moving forward, that MHCC would be the body, if you will, that would have the opportunity for all the stakeholders to be at the table to help figure out how do we move towards that end of a rate that would be acceptable, so we can have these providers, providers have the opportunity to be in networks, and so we can provide the care that we need here in the state of Maryland. The last thing I'll say, Madam Chair, is that we did provide the committee the 17 states that were referenced during the hearing, where there's been some level of opportunity for the payment of these services to be incurred by the carrier, simply because the citizens, again, needed the services of providers. There is going to be just a couple of amendments that I wanted to highlight for you. One is a technical that just specifically addresses that the Healthcare Commission, the word care is missing out of that statement. And then the second is that there was discussion, and Ellen is available for the additional conversation on this, but there's discussion with the MIA about what the language should be around a planned document. And that is referenced in the bill. And so we wanted to make sure that that had a specific meaning dealing with insurance contracts, evidence of the coverage within the contract, and the summary of benefits. So that's certainly a lot more of technical, but I wanted to highlight that for you. You know, with all the persons that testified, written or orally, in favor of it, have said over and over again, and the State Attorney General's office in particular noted the importance that, you know, we have these issues of being out of network, and we want to be able to address those because the citizens believe that they are getting this service within their contract. So those are just some highlights, but thank you, Madam Chair.
Yeah, thank you. Thank you, Delegate. So the delegate referenced you, Ellen Weber. Do you want to speak to the bill?
Yes, thank you very much, Delegate Collison, Chair Collison. In reference very specifically to the amendment that we are working out with Maryland Insurance Administration, those are the terms that we have worked out just to make sure that it's clarified as to which materials those this right to seek a non-network participating provider service is made clear. I think the one thing that's also very important to identify here is that if you take a look at the testimony, all of the major health associations have urged support for this bill. That includes MedChi, which indicated that access to critical mental health and substance use services continue to be a concern. The Maryland Hospital Association indicated that they can't discharge their patients to appropriate levels of care because of inadequate networks. And the Maryland Rural Health Association has also said enhancing access to behavioral health services is a major priority. And so while clearly there are improvements being made by the carriers in improving their networks, and because telehealth, obviously, legislation that this committee was instrumental in passing, that makes services available as well. There still is this ongoing concern that these medical providers are identifying. The 17 states was provided in my testimony earlier, and happy to answer questions about that, but all 17 of those states have adopted this standard that the bill provides for. Consumers should be charged no greater cost than their in-network benefit. As HEAU indicated, that's what consumers bargain for. That's what they think they're paying for in their premiums, and they are entitled to get an in-network service. So thank you.
Okay, thank you. I want to go to, seeing no other hands right now. I want to go to the, well, I do, but let me ask my question first and then I'll go to the hands. Commissioner Moraine, the language, as I understand it, in the bill is designed to clarify how a person can get an exemption, when there's a delay or there's not a provider close by, that there can be an exemption. And so am I correct in that?
So I'm going to defer again to Mr. Cooney, who worked on the technical language and was just on the phone with the delegate and Ms. Weber. So I don't want to misstate anything. I think I know the answer, but David, why don't you address this?
Okay, thank you, Commissioner.
Sure,
David.
Commissioner and Delegate. Yes, so I mean, pardon me, the existing law, that right already exists. So it addresses referrals to out-of-network specialists when there isn't reasonable access to one in-network. The issue with current law is there's not a protection from balance billing in those situations. So the insurance company has to pay in-network cost sharing, but the consumer can still be balance billed. So what this bill proposes is that it would eliminate the balance billing by ensuring that the consumer is made whole. But it should be noted the current law gives the right to the out-of-network provider, regardless of what your condition is you're seeking it for. It would include medical, surgical, and mental health and behavioral health. Okay. This bill addresses the balance billing just for behavioral health.
Okay. All right. Delegate Krebs.
I understand what the bill does. I understand the problem we're trying to solve. The question that the $1 million question is, if we do these things and it's not balance billed, what would be the incentive for any provider to be in network? They would never join a network because who's going to pay? Someone's going to pay this extra amount that this person is charging, I would assume. So that's the $1 million question. How does, we got a healthcare shortage, and it is a significant problem, the healthcare shortage, but if we mandate out-of-network providers provide services and no balance billing, who's going to pay that delta, and why would anyone ever join a network? That's my question. I guess I wanted to ask that question. I know Matt Salentano is raised that point, which is it's a little thing, but it is the elephant in the room.
So thank you, Delegate. So I'm going to ask Ellen to respond to it first, and then I'll come to Matt. Okay, is that all right? So Ellen.
Thank you for your question, Delegate Krebs. So this issue has been studied already in Maryland. Back in 2010, when the states passed its No Surprises Act, and I'll talk about the federal law in a minute, when it passed its No Surprises Act, General Assembly was very concerned about just that question. Would providers just flee the networks because they could always get an out-of-network reimbursement rate? MHCC studied that, and I'm not going to restate their findings, they're on the phone, but they basically found that there was not an exodus from the networks, that most of the non-network providers actually took the assignment of benefits standard because it lended certainty to their reimbursement. And that is the same problem that we're trying to solve for here. There are lots of non-network providers, many of them. That's why there's so many individuals with mental health and substance use providers, if they can afford it, going out of network, because they are out of network providers. It's just they're not in the network because the carriers are not providing a reimbursement rate that they can make a
But in the situation you just mentioned, what happened to the ones that didn't accept it? What happened to the payment? Who paid it?
The patient pays it. That's what
No,
happens.
but this would not allow the patient to pay it. That's my point.
That's correct. But right now, what we have is this massive cost shift, and it provides no incentive for the carriers to expand their networks because they know that they're not going to have to shoulder that cost. It's the consumer that shoulders that cost if they can't reach an agreement with the provider. And so that's the problem that we are really solving for. We are trying to level the playing field so that there is a fair reimbursement rate offered for a non-participating provider. And that's why we've requested in this bill that MHCC develop that through a stakeholder process. Now, the only other thing to know is that when we talk about if the carriers say that, well, those costs are ultimately going to increase premiums, well, in fact, that's not appropriate because they are selling a policy, the consumer is buying a policy with the expectation that they get in-network benefits for their mandated mental health and substance use services. So if they're saying that comes with an extra cost, well, then this policy is not worth what it's written on. So that's a real problem. And now the only other thing I really want to mention is that under the federal No Surprises Act, the federal No Surprises Act now protects consumers against balance billing for hospital services delivered by somebody who is not in the network. They protect that consumer against balance billing. And in that situation, the consumer doesn't even have to get approval to go to that non-network provider. It's now provided by law. So in our situation, there's even a greater need for this. These consumers get permission to go to out-of-network providers. They get acknowledgement by the carrier.
Okay.
They should not have to balance bill. Thank you.
Thank you. So I'm going to tell you, we have like 4 minutes left. I'm going to take everybody's hand that I have here. Just know we are going to carry this bill over to next week. And I am going to go, I think, Matt, I said I was coming to you, but I have a feeling that Kim wants to respond. Is that right, Kim?
I was happy to wait my turn in line. But I'm also happy to go first.
Right, good. Can you, someone, either Matt or Kim, respond to the issue of the incentive for people not to join the networks?
I put my hand up. I'm in line. When I get my chance, I'll go. But please, Kim, first.
Okay.
Sure. Thank you, Delegate Collison. So, oh gosh, so much to unwind here, Delegate Collison. So when we talk about, I think the first thing is, I think it's hard to compare what Maryland did with assignment of benefits and what we're talking about here. That is a very specific space talking about participating hospital providers who were participating in an in-network hospital, but the provider group was choosing to be out of network. And that was in many ways a setup for patients who were going to an in-network hospital in an emergency circumstance. They didn't have the ability to pick the provider. It's just not an apples to orange. It's an apple to oranges comparison. And we don't have time in 3.5 minutes to try to unwind why that is not the best analogy in this situation. But when we're talking about what we're talking about here, a couple of things. One, let's just start with the 17 states this is being compared to. I want us to be really clear that to just say 17 states have done this is a really misleading statement, in that 17 states have done a version of a hold harmless. There's not a single state that has done a rate setting the way this bill is proposing. So we've got two different issues from the carrier perspective. One, we've got the conversation around what a general hold harmless in this situation does or doesn't do to increase participation in a network. And I think Delegate Krebs raised the excellent point of, if I'm guaranteed to make more money for my non-participation, what is the point of participating? I think that is ultimately the elephant in the room when it comes to the conversation around how a hold harmless in this situation works, especially if we're in a circumstance where Maryland has a network adequacy law and carriers are already being charged with building what the state is telling us the state is accepting as an adequate network. and not finding deficits in this particular space, right? If the state is saying, here's the threshold and here's what qualifies as an adequate network, and you carrier, you meet it, and now here we still are going to pass a law that's going to say, but if you go out of your network, you can make more money. I don't know how those two things are working in concert to ensure that people have in-network access at the same time. Secondly, the idea of the state setting the rate is also problematic in so many different ways. Maryland does have this history of the setting of rates. That too is a much longer conversation that I would be happy to have with any member of this committee, because some of our formulas work better than others. Some of our formulas, I think, in the opinion of some of the carriers, have been anti-competitive and actually end up benefiting certain carriers over others. It is not as easy a fix as it seems to be. And the federal law is, again, far afield of what we're talking about here. I know our time is up and this is going to take a longer conversation, Delegate Cullison. It's a lot to try to respond to quickly.
Okay, thanks. All right, so I'm going to go back to Delegate Saab.
Madam Chair, I'm going to yield my time to
Okay.
I think Kim answered a lot of my questions, so we can have a discussion later. Thank you.
Great, thank you. Debbie, did you have another something to add?
Just real quick. I just want to explain the process, because I think what you just heard is not, I think it's important. Number one, both in our HMO and our PPO networks since 2018, we've added about 4,000 behavioral health care providers in just the past 4 years, in both the HMO and in the PPO. So we are trying really hard to expand our network. And what Kim just described, I believe, will be the exact problem of us having this ability to bring our people into our network. And now they're going to say, there's no need because I'm going to get this higher price that we can't even negotiate. So I'm going to stay out. So all the great strides that we have made will be potentially wiped out. Number two, the way it works today is when someone is it's really an issue in the PPO, which is where the balance billing occurs, because in the HMO where we don't have that problem. And in the PPO, when someone needs to go out of network, what we do today is first say, we want to bring you in network. Can we negotiate something? And we've been successful sometimes bringing providers in network. Sometimes we are not. So we end up then doing a single case agreement. In that single case agreement, we start off by saying, we want to negotiate with you so you can specifically see this patient. Let's negotiate a rate. The vast majority of times we are able to be successful to develop an agreement with that provider for that patient at a lower rate than their negotiated rate and then their standard fee. This bill will wipe that ability for us to negotiate anything lower than whatever the MHCC determines. Number two, part of that arrangement is if you're willing to have a single case agreement, you may not balance bill the patient. That's part of the contract. And you'll submit claims directly to us and we will pay you so the patient is out of it. That's how it works. That's how it's supposed to work. You're going to take that whole process away if you pass this bill with, I think, a lot of unintended consequences. So I just wanted you to understand the landscape, what's happening. We're all trying, not just Care First, but all carriers are trying to bring providers in. I think 4,000 in each network is pretty darn good over the past 4 years. And we do negotiate and work hard to bring these providers in, or at least make sure the member's not balance billed when someone has to go out.
Okay, thank you. So I'm going to ask Allison. Ellen, we're going to come back to you next week. Allison, Ben, and Matt. Allison, something additive.
Thanks. One thing I'd like us to maybe dive deeper on is we hear that the behavioral health providers are having trouble getting in networks. I'd like to understand a little bit better who, exactly what percent of behavioral health providers that is, and are they certain specialties or whatever? Because, we're not having big hospital systems here saying their providers can't get into networks. I would suspect it's the smaller providers, and that's a very valid concern, but I think it's a different issue than saying that the whole community has, and maybe I'm wrong, but I would like to understand that a little bit better. That might help us come to a more granular solution or a more targeted solution to the issue that's being posed here.
Okay, thank you, Allison. Ben, Stefan.
So given the amount of time, all I wanted to say is we think it's going to be hard for some of the reasons outlined. If it's the opinion of the General Assembly, we would try to do that. I think the issue here that separates behavioral health from surgical providers is that these are oftentimes much smaller practices and often don't go into network for reasons other than reimbursement. And we're going to have to address some of the challenges that Ms. Taylor also outlined, I think, if we're really serious about solving some of these problems.
Okay.
Happy
Thank
to
you,
talk
Ben.
further.
Okay, thanks. And I'm going to go, Matt, your hand went down.
I'll give my time to Delegate Sample Hughes.
Okay, and then you got the final word for today, Delegate. And clearly, we're going to be discussing this again.
Yeah, absolutely. And I won't go into each point that has been shared by the carriers, but two things I just wanted to highlight. The statement by Ms. Taylor was just raised about not hearing from any hospitals of their concerns, but the Maryland Hospital Association provided a letter, and in their letter it specifically says on third paragraph, second sentence, data shows Marylanders with commercial preferred provider organization plans are 10 times more likely to use an out-of-network provider for behavioral health office visits than medical surgical office visits. So again, this is something you can read yourself, but the Maryland Hospital Association did weigh in, and that is the response to your question. And like you said, Madam Chair, we have a lot more conversation that needs to be had on this subject, but I would just employ others to look at the testimony of those entities that have raised their concerns. And it does specify some of the things that were brought up here today. So I'll leave it at that. Thank you.
Thank you very much, Delegate. So to the committee, I would say things are going to be very busy. As you can see, we have three, pretty significant bills. Please watch, listen. We may need to double up on subcommittee meetings next week. I'm not saying that we will, but I just want us to be prepared in the event that we do. There are some rather significant bills coming before us soon, in addition to the ones we just have. So, like I said, get good rest, eat your Wheaties, and now you have committee members. You have 24 minutes before our bill hearings begin at 1 o'clock today. Thank you all very much for some great discussions, and we're on to hearings. And with that, this meeting is adjourned. Thank you.